program, we had highlighted a few questions to pose for people to think about in terms of what are the key barriers and challenges, based on a lot of what we've heard today, that limit the success of diabetes treatment and management programs across the country. Some of it obviously is access to data, and other ones is kind of sustained approaches beyond research projects. How do we scale and spread and keep sustainability? And are there common approaches or characteristics of successful programs that can be applied across the country? So we'd like to interact and hear from people of, hey, that really I thought was an interesting thought or idea. And some key lessons that might inform some pan-Canadian strategies and priorities for more targeted policy dialogues or research, because this is the beginning of a conversation, and I think from a number of players as we've developed this program are really interested in that this is part one of a bit of a phased effort to continue in engagement of how we might be able to support to address this particular problem. One thing I would note, when we first started discussion on this, we were aware of the Canadian Diabetes or Diabetes Canada guidelines for Indigenous health in treatment of diabetes. And we first tried to frame the program around that. And we said, well, why don't we just pick a couple of them and see what we might do in implementation? And we were told at the time, well, that's not the best thing to focus on right now because they're in the midst of being updated. And so a large number of you would know is that those are being updated right now. And Seema, is Seema here? Oh, there you are. And actually, I might ask Seema to provide a kind of bit of an update just around the timing of when the updated guidelines might be made available or presented to the public. I think it's early sometime in the spring.
It's actually the practice guidelines.
Okay, sorry about that.
Diabetes Canada launches clinical practice guidelines, and there is a chapter on Indigenous health and diabetes, so that's what you're referring to. There's not specific, clinical practice guidelines. The chapter is dedicated to Indigenous health and diabetes. The plan is to release it in April, and it'll be launched then. There's, of course, emerging data all the time, and there'll be new data during the conference this week, but there'll be no release of the guidelines per se during this conference.
Right. Okay. No, thanks very much. Just wanted to highlight that next year that was something that was going to be happening related to a guidance document coming for Canada around that particular area, and we're hoping to, once that is released too in April, to try and see how we might look at approaches that would help move the guidance of what is best practice into reality. And that's a lot of the discussion we're having here. How do we make actually some of that successful scientific knowledge about what works best to be kind of implemented across the country. But I'd like to now, to moderate this, our discussion period, is to call on Dr. Keith Dawson, who is a longtime expert and in this area. Was a professor of medicine at the University of British Columbia, is an endocrinologist, has spent a lot of his life studying diabetes, and to moderate this discussion period and provide some comments.
Thank you very much. The big problem here is to get people to contribute, because at this point in time, we've been given a tremendous amount of information. First of all, I want to congratulate IT on the background paper that was provided with us. That's a vast resource of information that's been made available. I hope everybody has looked into it and formed an opinion about it, because the information that's been provided is terrific. What is it based on? It is, what is the incidence of diabetes? And you've all noticed, I hope, that the incidences vary depending upon the source of the reference. It stretches all the way from very small, 18% is probably, up to 88% of Indigenous people at the age of 40 will be expected to have had diabetes before they die. 88%. So the incidence of data is very variable. And the real problem is we have also been given a great deal of information about, particularly from Chief Bobby in my view, about how best we can start approaching some therapy, some things to do. But first we have to identify what are the key barriers. And I'd like anybody to speak up and say, what have you found, not just at this meeting, but what have you found is the big barrier that you'd like to overcome? Anybody, speak up and identify yourself.
Okay.
Dean? What are the chief barriers?
I'll mention one, what I didn't say in my talk, is staff turnover within the communities. Was a
Are you referring
big,
to the nursing staff?
to the nursing staff,
or the doctor
LPNs, community
staff?
health. No, more the nurses and community health workers and LPNs and those types of individuals. There's nutritionists, all of them.
How can we deal with that? In other words, is there any way to tie it over so that the turnover, they still will persist in presenting a program that's good? Or no, we've got to start from scratch with a new person and she has to get to know everybody in the community? Or we have to live with those doctors that are changing, coming in from South Africa and going back to South Africa? What do you think the solution? Because this is a real problem. Turnover of staff, healthcare workers, nurses and doctors.
Can you answer that, Dean?
I think programs like yourself and what we've done where you have kind of a centralized nurse who may be involved with these communities can help bridge that gap. They provide that stability of knowledge and that for the community. So we've really found that with our program. You know, our care coordinators have kind of moved from that initial person providing education to actually the pillar of their diabetes care within the communities. And so the staff turns over around them, but they still are the same individuals, and so they have that institutional memory in terms of what's going on with the community health centers and that. And so for us, that's been a real bonus out of it all for the communities.
You've touched on two things there for Dean. One is this turnover, and secondly, the ability to have a program continue. Jeff Redding, you were knowledgeable about this whole area, both on the Mohawk communities and in the Vancouver area. So can you give us a comment?
On the barriers, specifically?
No, on what? On the whole thing, the impediments to delivery of the care.
Sure. Well, you know, I did take notes from the speakers, and I tried to synthesize what was said, and I think some of the notes, the influence of mental health and well-being, you know, the notion that diabetes is the target organ is kind of the brain. You know, it's really about, I think our elders told us, loss of hope. You know, what's the storyboard of Indigenous healing? How does diabetes turn into recovery, and how do we reclaim well-being? And what is the trajectory of getting better and wellness rather than the trajectory of illness? And I think the multi-generational trauma exacerbated by poverty are really driving diabetes, and diabetes is really just a symptom of the multi-generational trauma and the poverty that's been experienced by communities. So it's been 25, 30 years of working, starting with the Ganawage Diabetes Program, and to be honest, very little has been accomplished in that period of time because we haven't addressed the underlying causes of causes.
Well, how can we pass those barriers, Jeff? I mean, you're
Well, there is a reconciliation agenda going on, and you know, it's a good signal.
It's a
We're
first
starting
step.
to get at the root causes of illness and poverty.
There's just some,
Sure.
I think in terms of your first question, of the barriers.
I just wanted to speak to that point on staff turnover, and I've heard several people so far in presentations saying, well, this nurse or that person wears multiple hats, which says to me they're doing multiple jobs, which tells me that their workloads are unsustainable, which tells me that our systems, you know, are creating job descriptions that don't necessarily address community needs, that people are working off the sides of their desks and not being supported in the necessary work that they need to do. And staff turnover in turn speaks to another issue, which is cultural safety and relationships. And we've gotten feedback from our communities that when health workers leave, it's traumatic, and it raises some of the trauma, the separation anxiety that comes from residential school. You know, there are a lot of issues wrapped up in that. And just on the point of cultural safety, you know, my inkling, I'm hypothesizing, I don't really have any evidence on this yet, but when we have culturally safe services where we have long-term relationships between health workers and communities, community members really value them and they seek them out.
Anybody confirm that or have anything to add to that statement, that concept? Yes?
Thanks.
I was just going to suggest, in the spirit of reconciliation, maybe we can start looking at how better to invest in the people in the communities and look at upstream investments. For example, when we're talking about health and education in First Nations communities, we know that the education levels are quite low. Not a lot of people are able to go out and get post-secondary educations. So we can look at a way to raise the importance of education with early ages. Obviously, we're not going to see the benefit for a number of years, but if we can start targeting those young kids in the communities to start thinking about how they can go out and get educated and be able to come back to the communities to serve their people, that's just something I'm thinking about in the spirit of reconciliation.
I happen to know that at the University of British Columbia, I think we have 16 First Nation people in the medical curriculum now. So there's going to be a sea change, hopefully. But it takes, as you said, that'll take a number of years before it comes to fruition. Lerinda, right?
Sorry, I'd just like to make a comment about the education. I am actually a registered nurse who's been working with the Siebert Mobile Diabetes team in BC, and that's one of 3 teams that we have in the province. Matthew beside me, he covers the north, I cover the south, and there's also a team on the island. And what I've seen in the clinics that I've gone out, yes, we have the tools, yes, we have the standards and the guidelines, which is great, but when you're actually sitting there with the individual, and I've just as guilty as every other nurse, repeating those guidelines to them, saying what they should be doing and sharing and asking that question. The first thing we ask when they come to see us is, how can we help you today? So that may be diabetes, that may be, you know, safety, it may be, you know, food security, whatever it is. That's the question. We unfortunately, in our kind of clinic environment, because we're immobile, we only get to see them for that half an hour when we do, you know, their testing and try to share as much as of our knowledge with them and they share with us. But one of the questions I've been asking is that, because they hear it often, so many times a day, you should be eating right, you should be exercising, what's that look like, right? And so what I've asked them is, do you know what a carbohydrate is? And they're like, no, I think so, it's sugar and everything like that, which is great, but they don't. There's so much more. So we begin our conversation on what is a carbohydrate and what that actually looks like in you know, the value of a teaspoon of sugar. Before I know it, my half an hour is turned into 45 minutes to an hour, and they get up and they leave and they say, you know what, nobody's ever shared that with me. As simple as that. And that's all I'm asking them, is to look at, you know, what their sandwich cost them, you know, in the sake of how many teaspoons of sugar. And of course, the other thing I run into in my communities is that the band stores, they have so much, you know, junk food. And I'll be honest, I'm going to do a disclosure here. My husband works for Old Dutch Foods, potato chips. We have such conversations at our dinner table about how many First Nations community, how much product gets sold in that community and how much money Old Dutch Foods is making off of these communities. And I just cringe. And I have this conversation with them every day and saying no, but I also have, you know, my coworkers saying, did you bring some potato chips today? And it's like, no, I don't want to bring potato chips. Don't you understand? It's simple things like running around your kitchen and finding out how many teaspoons of sugar per packaged food that you have stored in your cupboard and getting them to look at it that way. It's a small step, and a lot of us know that education is really important. But for them, that's the most that they can handle in my time period. They don't care about an A1C. They don't care about the complications. They care about just the very simple things. And I'm hoping, next time I come into their community, that they're going to ask me more questions. And I do leave them my number so that they can call me as well. But I'd like Matthew to actually make a comment too.
Working as a diabetes nurse in a lot of remote communities, I often thought to myself, what was the number one thing that really hit me when I met with patients, folks with diabetes? And that was the ABCs of diabetes was really missing. A lot of folks, we talk about key barriers, a lot of folks are used to going through the system of a physician or a nurse saying, oh, we need to do this with your insulin and do that and exercise more and eat less this. And at this most basic level, folks do not often have a basic understanding of what diabetes is. Has anyone ever explained at its very root what is diabetes? Using models, very simple explanations. And using that as a tool of empowerment. We might as well forget about the rest if we can't start. Even for a lot of folks, we develop our tools and our presentations at a grade 4 level. Very visual, very pictorial with a lot of models. And it's alarming to me every time when we come back from a community, the number of folks who say, oh, has anyone ever explained to you what diabetes is at its very root? No. And so how can we even start to begin to empower people with diabetes if they haven't, in many cases, been given the tools necessary for that initial empowerment? The listening that Chief Robert talked about, folks being able to tell their individual journeys, a lot of that comes from the explanations, the time. We have to invest time. I heard from one of the presentations, listening more about the journeys, and we're so often focused on rushing people through appointments after appointments when we really have to invest in time and in the quality of those appointments, using the tools that we've been given, and really bringing the education down in many cases to grade 3, grade 4 levels to help explain. Oftentimes I don't understand a lot of medical concepts unless they're explained at that level. So we have to, I think that's a really, really, really big barrier that a lot of folks even in the medical community still haven't gotten, and it's a huge challenge. Thank you.
Could I ask anybody in the audience, my own biases obviously come out. I happen to believe that we need a massive education program for healthcare workers, how to present this type of information. With that, there's no resource for doing that. Forge Ahead is looking at that. They have the bootstrap thing, and there's other groups that are trying to train them. Not just the person, but also what the person is to present and how they're to present it. Does anybody have a good curriculum that you could turn over to a group of community healthcare workers and say, go through this curriculum, learn it, understand it yourself, and then disseminate or discuss that with your patients? Starting at, what is diabetes? Starting at, what should I do? And let me give you one thing. How do we motivate people? We are terrible at doing that. Our healthcare community, in my view, is terrible at motivating people. We say, go do this and go do that, and everybody's agreed. All the speakers today said, telling people to go do something or to get their A1C down or to take their meds is terrible. Remember, 44% of people after 2 years are no longer taking their meds. 20% of people discharged from a coronary care unit, having just had a coronary, 20% of them never fill the first prescription their doctor gave on leaving the hospital. We're doing a terrible job in this area, so I think we need a heck of a lot of work. I'd like to propose something that Hesham and I believed in years ago. We created this Live Well with Diabetes, which is an internet, so anybody can go into the internet, go in, and Live Well with Diabetes has all this described. What is diabetes, how to do it, et cetera, et cetera. And in Diabetes in My Nation, there are people discussing each of these things. I'm raising the suggestion that how do we get people to pass on that type of information? And one of the ways, I think, we can't do it with sending out Lerinda and Matt to every community. There's 197 communities that this clinic serves, and how can they possibly do that? We have to get people to do it in the local area, and they need something. I believe telemedicine with telephone. And in Africa now, people are taking care of their HIV by cell phones, taking their meds, what is the disease, etc. This is what we need to do, but we can't do it unless somebody has a bright idea how we can train people to provide that at the community level.
Well, thanks. And I know that Dean had presented some work on radar with some of the kind of group they might be in. There's a lot of kind of activities to be able to use remote or shared services that might support people in local communities. But a bunch of hands went up, I think, around the whole issue around behavioral issues. There was Jeff here, and if people could hold the mic close to their mouth, that would be great, and we'll run around.
I just wanted to make two quick points. One is we could take a lot of inspiration from the HIV community, because there was First Nations women who were HIV positive, and when the antiretroviral therapy came up, it was no longer a death sentence, but there was resistance to taking the medications, which were literally life-saving. So they did research with the Canadian Aboriginal AIDS Network, and what they showed is the notion of relational care. The idea that the caregiver and the patient established a relationship of caring that was reciprocal. And that idea allowed, because the patient felt that someone actually cared about them, the level of trust was built, and then the patient was able to take the medication and be more compliant with the drug. So I think it's about, and the Truth and Reconciliation Commission also made a recommendation, number 24, I think it is to look at the curriculum of healthcare providers and be able to, look at the kind of needs that are in the community. And I know medical schools and healthcare settings are starting to do that.
Just here.
Okay, well, you talked about things like how people are not compliant with things, but like for us in Ganawage, I'll say that we have a lot of visuals in the community that kind of always remind people of how powerless sometimes we are as Indigenous people. We have the bridge, the Mercier Bridge that connects us to Montreal. We have the CPR bridge which connects us to Montreal. We have hydro lines that go through the community and have taken up, land. We have the railroad tracks that also takes up land. But most of all, I think we have the St. Lawrence Seaway. And that's a very visual thing that we see every day going through the community, and that reminds people of all the people who had homes along the river. And the river was our source of life, and it was also a social gathering place. And it was in the newspaper in the 1950s whereby they took everybody and expropriated that land, but there was an older woman who did not want to leave her home, and she actually wanted to die in it. And at the time, it was the RCMP that were the police force in the community, and they actually took her out of her home and detained her until they tore down her house, so she had no home to go to. So those are stories that our children hear. And so besides the reconciliation thing, there's empowerment in telling the story, but telling it not from an angry perspective, not from other than telling a story, so that they know the history of where we come from and what our people have gone through. And the other point I'm addressing is that you're talking about looking at the curriculum and how can we get curriculum for these healthcare providers. And in my talking to two people that were asking me at break time, I said, according to our code of research ethics, the best way to introduce a researcher into the community is come and volunteer for some of the activities that we have in the community, so people get to see you face to face. And so when you're going to knock on their door as a researcher, they already know who you are. Oh, I recognize you because you were at one of the activities, and so on and so on. And how can you, why are we looking for funding for curriculum when you put people in a place of volunteering their time and you give them the curriculum or whatever it is that you want to do, and that you make them as an example of what can happen, and then you get the money. Okay? You do it.
Get it later.
You do it the other way around.
Okay, thanks very much. I think just back here was just before.
By the way,
I'm trying to be the fairness with the mic, please.
Could I have just one
Thank
comment?
you. Hello?
In BC, we never use the word research going into it, even by a First Nation person doing it. There's such antipathy to the word research because of the reasons that have been shown on the slides. Oh, we've done the research and you never did anything for it, never helped us. I don't want anything to do with research. So you say, we're here not to do research, but to learn from you how we can help you best. How can we help you? How can you help us? Anyway, that's what I question.
Okay, my profession is a dietitian. That's my nutrition background. I used to work in Norway House, and when I was doing my master, when I did my PhD, it was gestational diabetes. I didn't go that far. I have good news. I understand the turnover on reserve. I've been going to First Nation communities, I can only speak for Manitoba, since 2004. One thing I figure, my observation is quite consistent, there's less turnover, is the CPNP coordinator job as a Canadian prenatal nutrition program. So, I mean, there's the election, there are admin changes, but whoever at that level, at the CPNP level, is always the same coordinator. Maybe, somebody, retire or move to another community, but that has been very consistent. So speaking of curriculum, there is a very nice CPNP binder, they give to the community coordinators, and that is as the train the trainer. You cannot fly doctors in from Africa, to do all this job. You have to build it's a community capacity building. So the CPNP coordinators, they are from the community, and then they go to Winnipeg for a 3 days or maybe 2 days conference and they get those training, and year after year, that's what the purpose is. They are not going to do individual counseling, but they can absolutely deliver prenatal education to the moms in the community. However, everybody is different. My observation is some CPNP coordinators through the years, they still don't feel comfortable, having a prenatal group and deliver whatever is literally in the binder with games, icebreakers, tools and toys, and it is an education toolkit, very nicely organized. They still don't feel comfortable. So what happened in the community is they turned the CPNP prenatal class into a sewing class. Because sewing class and the mom's probably gonna come out to sew the, what is it called, the baby carrier? There's, I forgot the term for that. Yes, to sew something together, and then, or even sew the receiving blanket. And more moms come that way, and then they try to deliver a little bit of information. And then they also invite elders to come out to teach the women how to sew. And that is a good opportunity. You know, we get the moms come out. So I also want to anchor on the social media, because when I go to First Nation community as a guest speaker to do prenatal class, because they don't feel comfortable doing themselves, nobody showed up. And then that's quite expensive for me to go out. But then the CPNP coordinator will say, hold on a minute, Amy, I'm going on Facebook. So she will go on Facebook, say, Amy is here. And then everybody got that message, and then some of them, they have cars, they will come or got picked up. So using Facebook on social media is absolutely a very useful tool. So I'm not going to do promotion for my study. So we decided a website, it's called momsinmotion.ca. So for the moms who does not want to come to the prenatal class, which they have a reason, they have 5 children at home, the health center only have 1 minivan, cannot pick up everybody, come to the prenatal class. And some reserve has 100 birth rate per community. It's just impossible for everybody come to the prenatal class. And then they can, since they can go on Facebook, they can go online and get some education that way. It doesn't guarantee exposed for education to education, gonna reach directly to the outcome of preventing GDN. But you know, the more exposure they go to for education, the better.
It sounds like you're doing a Trojan horse there. Come on to our sewing lesson, but meanwhile, I'm going to teach you something else.
And it's interesting, just, I know there was a lot of discussion earlier about reflecting back to communities about the population statistics and information about how their community's doing and their health, but also the basic science issue about what diabetes are. So there's different levels of education, but that information sharing is obviously really important as we try and address behavioral change. And if someone could make a pill, Bullringer, that would kind of automatically change people's behavior, or it would just be a kind of a miracle. But Hashim is first and then back to you.
Well, so we heard that one of the main problems is the turnover. Nurses don't stay, and the nurses are overworked. And the definition of insanity is trying to solve the same problem using the same methodology or the same people. So why we don't think a little bit different? If we think of diabetes as a healing problem rather than a medical problem, maybe the person in charge of mentoring patients or working with them or healing them is the traditional healer of the community. You know, I know many people don't believe in the medicine man anymore, but they do an excellent job if you listen to them. And in the old days, from what I learned from communities, when a community loses their healer, they bring the neighboring community will send someone to teach someone. And for example, in the Haida Gwaii, they have a Mohawk traditional healer, which is strange for the different environment. But I think you want to look at it from a different angle rather than trying to say, how can we keep the nurses in, or how we can keep this? It's not the nurse's job to deal with that. The nurse has always, most of the nations don't hire nurses from the community. And you all know that because of nobody wants to tell the other family who has what. So they bring nurses from other communities who take some time to build a relationship with the community, and by the time they build a relationship, they leave. So I think healing should go back to traditional healers, maybe. And that's all what I have.
I think just one comment, not on there's a traditional healing aspect, but I do think particularly Western medicine has a significant approach to a professionalization of healthcare delivery and significant professionalization that you have to have a certain level of expertise to be a diabetes educator. And I think certain types of diabetes educators do, but there's lots of people who can be diabetes educators as family members and as community members and individuals. So I just think it's just that one comment on looking at traditional healers, but also communities taking on roles in well-being that don't necessarily provide professional qualifications in order to deliver it. But you had a comment.
Oh, yeah, as you were talking, I was thinking about PNP and sewing and how to bring people to programs. And one of the messages we got from a recent round of community consultations was that men don't really come to community programs, and they don't come to screening nearly as much as women do. Am I correct in that, Matthew? Yeah.
Well, that's what we
So
found,
this
but I
is-
noticed Dean's had more men than women. I was amazed. But there's a difference between the sexes. So if you have male sewers, maybe you can get them to come in.
Oh, just here, yes.
So this is really interesting timing. This morning, the Board of the Diabetes Communicator met. We have 4 issues a year, and we always theme them, and we've decided for the first time, everybody agreed that it's not private information. I'm putting it out there. Am I being taped? In the summer of 2018, the whole issue will be dedicated to diabetes and Indigenous people. And I just spoke to Chief Joseph and asked him if he could condense his talk into a lovely little article. Hope I'm not putting you on the spot. That will set a lovely precedence, because the conversation that we had in our meeting is we really, so agree with you, Dr. Dawson. We need to educate and spread the knowledge, because most of us don't know, and we don't know what we don't know. So Amy and I are both on the board, an open call out. If anybody, I would love to be overwhelmed. If anybody has an idea for an article, come and grab one of our business cards and send us an email, and we'd love to chat so we can put together a real kick-ass article, or issue, sorry.
Well, we'll certainly commit to provide the network back to you through communication from this event of particular kind of resources, as we said, and follow-up activities. Just as a note, in speaking to some key people across the country, as a decision makers, we're the Institute of Health Economics, but a significant interest is starting to happen in behavioral economics, and how do we not just study the cost of various things, but how do we influence behavior, and how do people make particular kind of choices to do it? And I think that's going to be an increasing focus of discussion. How do we get someone who knows that they should be compliant with medication? How do we get them to achieve it? Is it through peers telling them? Is it through the power of grandmothers and actually grandparents, I think, in significantly addressing the needs of their kids? Things that have happened in people getting vaccinated. Things like, I know, consent around organ donation. There's a lot of approaches where one puts in programs where there's presumed consent and people have to opt out. And they can consciously opt out. But most people follow with the flow, and they end up presuming to consent. So one can use how you structure your public programs to make it easy, to make the choice, the most healthy choice, the easiest choice, and going through that. But
hi there. I hear the words coming out of everyone of the connectivity and how that education is shared. Through the residential schools, we've lost the connectivity and the kitchen table knowledge that can be handed down so that people are educating their own. That was interrupted. I'm a 30-year nurse, but I'm also a mother of 3 adult children. And I'm also the spoke of healthcare in my community, where people call and consult and they find answers and resources that way. And I think that's where our strength will be in changing behaviors, is in empowering families and empowering community to influence other behaviors. I think you have a beautiful model with Diabetes in My Nation. And I think it's those circles of support through community centers, through social interaction, through the social ventures of supporting one another, calling one another to better practice and behaviors that will have a greater impact. And the model of all of your communities that you're helping through BC, and you can't get to enough people, that you're teaching carbohydrate use in a meeting with a face-to-face with a nurse, and that's not happening at community centers, at the dinner table, in our families and amongst our friends. There's the lack. And as a nurse, I've been overwhelmed when I walk in with a client and they haven't done anything to help themselves and their own well-being for 38 years, and now I have a 50-year-old man who has no idea that he should drink water. So you're running yourself up against a wall when, if I can just take care of the healthcare portion of it and the nursing portion of it, and I don't have to do all of the lifespan of education, my job would be easier.
There's no question you're right. There's no question that we need other people in the community. But let me ask you a question. How are you going to get those knowledgeable parents when they haven't got the knowledge? How are you going to get them to be spokesperson in the community? How are we going to do that?
Through your idea of sharing that curriculum throughout. The Indigenous Wellness Program has some excellent curriculum, and empowering groups and community groups like you're sharing. I think that's really the answer.
Well, the Gognawaga group really did do a huge effort, I thought terrific in the obesity area, and it's tough to do. That was a massive effort on their part. It was terrific.
There's just,
I don't want to take away that there is probably, a high rates and stuff, but I think individually, communities themselves, like Siebert Island actually has an approach to gathering traditional foods, doing canning, having a traditional food bank, empowering their community members by, providing education. So it's not just the nurse that's doing the role. It's not just one, department doing the role. We have multiple departments that are trying to work together. And it's difficult because we sometimes don't communicate, but when we start seeing people gaining skills like education, we have a driving, teaching people how to drive so that they can actually get to a job interview. So we've got, it's at multiple levels that we're seeing success within Siebert Island, but that's only the one community, and my role, is multiple, doing home care, community health, as well as the mobile diabetes. So it doesn't, it takes me away from, just focusing on the diabetes, but there are other things that we do. We have the food banks, like I said, so we have people that go out and hunt and fish. And it's hard for communities to, just get a gun or, get a boat and go out. It costs money for that stuff. So our band pays for that so that they can have gas, so they can go on the river or the ocean to gather their food. We need to be role models at our events. When we go into the big house, when we're feeding people, we can't have tables full of carbohydrates. We need to have, their traditional foods there. We have a dietitian that works with our team. We have our techs. We have our doctors. So we're kind of considered one of the center of excellences in BC. So we've got that role. And of course, we've got our nutritionist and our, sorry, I'm losing my words right now. We've just had so many different programs that we can implement all together. So I don't see us failing. I see us working together, and it'll take years before we actually see those numbers starting to come down, and that's what I'm really hopeful, that we won't lose that team and that momentum.
Thank you. One of the common themes that I've heard here today is the time factor. Some nurses in the room said they haven't had enough time to do this, and the importance of time in building relationships, and the importance of time in helping to empower people wherever they are on their journey with diabetes. And I just wanted to get back to a point too that I think it was Addie had meant earlier, in that improving First Nations health will take money. And so there's a number of communities that we visit annually where diabetes rates are higher than others. And so there, as advocates for people with diabetes, as diabetes nurses, the room is filled with people who are advocates for those with diabetes. there are many places where additional funding to support diabetes nurses, to support diabetes prevention workers in community, but that also takes money. We need to be realistic, and also to advocate for funding for those positions, because to improve, we've heard the common themes of time, and yes, not all time requires money, but the time to often listen, to do the work that we do, takes money. And so wherever we can advocate for more money for the cause, we need to be strong in doing so. Thank you.
And certainly I totally agree with the fact that significantly additional resources are needed, and also presentation of evidence of the particular burden and the particular need, in which is a significant major, no, I won't use the word crisis, but in the Canadian healthcare system, diabetes as a kind of focal point, and Indigenous health generally, certainly warrants a significant dedication of additional resources, and actually it prevents high-cost resources that might be used over a longer term investment now. So I know there is a fair amount of work looking at where you need to kind of see what access to the infrastructure is required. You need access to appropriate medications, diagnostic screening, those particular kind of things. But then it's frustrating when even those things are available, that there is poor compliance, lack of uptake and implementation, sometimes even when resources aren't the particular problem. But some key areas clearly is the lack of personnel and resources.
Yeah.
But
I just wanted to quickly say I kind of object to a lot of the language that's being used in this report, because it talks about cost and financial burdens, and it talks about Indigenous populations. So when you look at it, it's easy to say that Indigenous populations are a financial cost and a burden, whereas I think we need to think more about a value proposition rather than a cost or a drain in the system. When a person talks about heart transplants, they don't talk about the cost of the heart transplant, they talk about the value in extending a young person's life because they've got a new organ. It costs a fortune, but we still do it because there's a value proposition. And this whole thing about saying that we always seem to look at Indigenous people as a drain on the system rather than a value to the system. And it needs to focus more on social, health, and cultural assets rather than liabilities. And that's the problem I have with economic analysis. It always focuses on the cost of things without assessing the value of things.
just one comment, but I'm sorry if that was a presentation of information, and certainly at the Institute of Health Economics, cost is not the only thing that's looked at. Is there is a numerator and a denominator in economic evaluation, in which but when there is significant cost which comes where it is potentially preventable, there's an opportunity cost of where it might be spent elsewhere, and certainly there wasn't. The most of the reason that you address illness and address problems is for the value that it brings to individual people.
I think he's addressing the emphasis on it being a negative factor rather than a positive.
Absolutely.
Roger has a question. He's got to defend. He wrote it.
Yeah.
Give him a mic.
And I was very conscious of that when I was writing it, so I'm sorry that it came off that way. But I think what we are trying to show is more of a business case of saying, you know, if we prevent diabetes, if we prevent the hospitalizations and the long-term complications that arise because we're not managing it upstream, like here's these cost savings that could be realized. And so it's more of a, I guess, a business case of really just focusing on the prevention aspect. So.
But I totally understand the point. Where should I go? Here.
Hi, everyone. So my name is Chantel Large, and I'm from Satellite Cree Nation. And it's only my second week in this new job that I have in research, so I'm a little bit nervous.
High turnover?
But I have a couple of comments, and I hope that everybody knows that when I say my comments, I come from a place of love and respect, absolutely. But in terms of this document, when we started, like before I came, right, I remember reading through this document and thinking, and I'm gonna share with you guys some stories because I'm relationship building with you guys as I'm going along. But I was reading through this document, and I really love sugar. And I have a stepson, and when he was about three or 4 years old, we were at the store, and he said, "Can I get this?" And I said, "No, you can't get that." He said, "Well, how come?" And I said, "Because it has too much sugar." And he's like, "Well, what's wrong with that?" So, "Well, sugar's not good for you." And he goes, "Oh man, I love sugar." And that's me. That kid is me. I love sugar. So you can imagine me when I was reading through this document, and I was thinking, like, oh geez, I'm going to cost the healthcare system a lot of money one day. But that was my perspective, right, and my feelings as I was reading through it. And then I was looking at diabetes prevention and management in Canada, right, and these DOHs in Indigenous populations, and looking at income and social status and poverty and employment and social supports, and then it feels like a burden, right, but we're not looking at like the larger system issues, right, and when we're talking about the barriers and challenges to these program implementations, like I think that it starts with us right here, right? And it starts with us in this room. Like for me, it's very awkward for me if we're having a round table and I need to talk to people like this. Like it's very uncomfortable for me to be talking to people behind my back, right? So I think it starts in this room and it starts with us. And for me, I'm very fair-skinned, right? So lots of people don't know that I'm Native unless I tell them. And so I'm constantly examining my own position of power and of privilege, right? And yeah, I think that's it, really. I think that's what I want to say, but we're talking about challenges, and you can tell a person who is First Nations in the way that they present these challenges and the way that they present these barriers, or somebody who's been heavily connected to the community, right? And I think that's what we're missing sometimes even here is just that connection, right? And that's why when I'm talking to you, I share my story of myself and my family.
Thank you very much. Yeah.
I just want to address one thing about loving sugar. Because I love chocolate, and I'm workaholic. And one day I spent actually 6 days working on a program. I was writing a program. And I noticed at the end of the 6 days that I'm using, just magnifier to see my monitor. Because all what I had was chocolate and ginger ale, and a wife that was calling all my friends to get me out of the office. I lost my eyesight. I couldn't see for 3 months. And I lost 45 pounds. I lost every single muscle in my body. So it doesn't matter how much it will cost the system. It's how much it will cost you. So I made it very simple for me. Very, very simple. It's I can see the chocolate and eat it, or I can eat it and never see it again. So it's not a rocket science. It's just your health. So all these numbers and all this mumbo-jumbo stuff doesn't mean anything. It's the quality of life. Like I don't care to live to be 200 or 100 or 50. It's the quality of every day. And diabetes can be a very unpleasant thing to have. So please think about your chocolate again, or sugar. Thank you.
I just wanted to say something. I really appreciate what you said about value propositions, and I think a lot about evaluation because one of my elements of my job is to sort of do this kind of assessment of the Aboriginal Diabetes Initiative and what kind of benefit it's having. There's the word values is in evaluation, and I'm thinking a lot these days about whose values count, and thinking about what this means when we're working in a pluralistic health system where we are talking about bringing in traditional healers and giving equal weight to these two systems. And then, of course, there's the problem of rigor and evidence and so on and so forth. And I say we have to weight these things equally. We have to come up with Indigenous lens evaluation methods that are designed with participation of communities, that are used by communities so they can assess the value of their own programs to them. So it's not just about cost avoidance and all of these orthodox valuation methods. And I do understand the importance of those, but at the end of the day, the programs also have to have value for communities, because communities are on their own journeys and define their own journeys and count their own steps, and the places they're going are not necessarily the same places that the Government of Canada is going. And so I really would like to make an appeal here for us to start thinking about the ways we can give equal weight to different evaluation paradigms and methods. Because at the end of the day, one of the great sort of power structures that's in place is that the people who are making decisions at the top look at spreadsheets, and it's really hard to get spirit into a spreadsheet.
That's very true.
That
Could
is
I
a
say,
great
while
quote.
we're waiting for the next person to answer, one of the problems is that the measure of quality for a health-oriented Western medicine thing is improvement in the health, actual health, and they mean physical health. They don't mean mental health. And the fact that the First Nation people have much more spiritual look. Just the fact that they're sitting together and talking makes people happier. That is good health. That is success. The trouble is the ADI program is evaluated, should be evaluated on what material things worked in the healthcare system. But that isn't necessarily the whole answer, which is what you're just saying. There's other factors than just the health improvement. You know, Matt knows this. We've just written up the mobile clinic for the last 5 years. We've got 5,000 patients that we've seen, remote communities. We've got the same data on all these patients for over really much more than 5 years, but we're only looking at the last 5. And the First Nation community said, I don't want that outcome analysis looked at if it doesn't look good for us. And they are going to refuse it. And I don't blame them, because it's true, ADI might cut off funding for that initiative if it isn't, quote, good in Western eyes. But it's a tremendous program which has gotten awareness of diabetes, and it's just a different sort of an outcome that you have to evaluate. And this is further to your point. The outcome is variable, but depending if you're a First Nation or not. There's another one there.
Yeah, we just had a couple, and we're probably going to have to close up relatively soon to provide some kind of closing remarks, but we're going to be able to continue the conversation not only after this evening in the particular reception, but also I think on an ongoing basis. But I've got. Here quickly, and then there.
I have one more good news. Dr. Gary Shen just left, I realized. There is a cohort study done in Manitoba, a very large sample size from 1988 to 2011. It shows breastfeeding really can reduce the chance of getting diabetes for offsprings. And that significantly decreased actually in First Nation community. And that has been published in British Medical Journal, and at the IDF a couple years ago was announced as well. But when we look at the breastfeeding rate, if we're talking about type 2 diabetes management, we do exercise, activity, choosing carbs. If we focus on the next generation, if the mom can start picking up breastfeeding, and that already reduced the chance of the kids getting diabetes, we start at the very, very early stage. But when we look at the breastfeeding rate in First Nation community in Manitoba, it's about 30%. And then in urban, Caucasian is 80%. But we thought that is the tradition, right? The First Nation moms, they're supposed to just practice this naturally. But echo Chief Roberts' comment is the residential school influence actually play part of this. We're hoping the mom knows how to teach the young girls, moms, how to breastfeed, but then they themselves, they didn't go through experiences like this due to the experience. So I'm just thinking if we can find a way to restore that practice in the community, just promote breastfeeding, and that helps a lot.
Hi, it's Joanne Lewis. I'm with Diabetes Canada, a colleague of SEMA's. And prior to working at Diabetes Canada, I worked as a diabetes educator for 20-some years in a very multicultural area of Toronto, where few of my patients were Indigenous, so that's my disclosure there, and I never went and worked in an Indigenous community, so I have very little experience compared to what's in this room. However, I did want to comment on a few things that I've heard today, and one of them is that we talked about knowledge, and knowledge on the part of the healthcare provider, and knowledge on the part of the person living with diabetes or at risk of having diabetes, and I think knowledge is definitely just a part of it, and I think we need to recognize that. And there are a lot of similarities in humans, right, regardless of your culture or race. And one of them is that in order to be motivated to change, it has to be something that is meaningful to you. And what I heard today were so many things from different people, and I imagine you're all representing different areas of the country, or I'm not quite sure which provinces are in the room, but there are things that everyone can take away from what everyone else has already said. And one of them was, I just wrote some things that I just remember off the top of my head. Somebody said, you can't eat fish if you don't have fish. I don't know who said that, but I thought that's so clever. Because, you know, as a healthcare provider, you can talk about diabetes. You can be the expert on diabetes and bringing it down to very simple language and using lots of models, and it could be right down to an art. But if that person doesn't know how to fish, or if that person has a child who has a drug addiction, or if that person has all these other issues, is suicidal, for example, as a healthcare provider, it doesn't matter how beautiful your charts are or how beautiful your tools are. If you can't help that person address that issue, and as a diabetes educator, when I had people in my office telling me that they had all these other mental health issues or were feeling suicidal, I was at a loss. I don't know what to do with you because I'm not an expert in that area. And all the mental health services in this area are jam-packed, and it's going to take months to see somebody. Or this person doesn't have money to buy food, or the food that's available is old Dutch chips, for example. Like the type of food that's available isn't the healthiest type. So if we're not equipped, either as an individual or as a community, to address all these other issues, yes, working with the person one-on-one, bringing it down to their level of literacy and understanding and all of that is very, very, very important. But it's only a part of it, because the bigger picture is what is the environment in which they're living in. And somebody else said something like, the target organ is the brain. That's brilliant. That was, whoever said that, that was so brilliant. And so how do we work with the brain and the person? Somebody talked about, you know, an example where they were sending people to Edmonton 3.5 hours away for, was it an eye exam? And meanwhile, 300 feet away, there was somebody there. We need to talk to people. We need to get coordination of what's available. And, you know, do we have somebody to deal with mental health issues? Because I'm not an expert in it. One of the other things that people talked about was, you know, we have a care coordinator that's remote. Other people have a CHC. And so we're not all delivering the same type of care, and access to care is very different. There's mobile care. And so everybody that spoke today brought a piece of the answer with them. And it's coordinating all of that information. So that's all I wanted to say. Thank you.
There you go, Roger. That's what you have to do.
That was an excellent summary of a lot of the messages from today. That was
just gave
really
you
good
right
wrap
beside
up.
you, John.
There was, yeah, just right here.
Thank you. I'll try and be quick. Yeah, you did a great summary, and there's a wealth of knowledge in this room. And if we can just tap into that, which we are, I think we can move forward. I'm just looking at the questions on the table before I leave, and I just want to talk about the barriers and challenges. And my experience, I work in the north, live in the north. My experience is that although diabetes is a priority, and we acknowledge and recognize the prevalence, and that we can do some work, it's how do we get that attention to the issue, make it a priority in the communities and the response. Because we have so many issues And while we're aware of the seriousness of diabetes, if the issue today is the suicide or the motor vehicle accident or the boil water advisory, or I can go on and on and on, and we have 8 staff, they're not working on diabetes today, tomorrow, the next day. And those are our realities. And we have, I work on reserve, we have federal funds. All of the funding that we seem to get is in little tiny pieces, and we are in Treaty 8, Alberta. We have small communities and a lot of them, and all the funding is generally prorated, so we get little tiny pieces of everything, not enough to hire anybody. So it just keeps getting put on the person who might have a little bit of experience in health, keeps getting added to their plate, and then they get to try and juggle day to day, week to week, month to month, what the priority is and where their time is being spent, and they're drawn to the urgent matters of the day. So we find that as a challenge over and over and over. Our staffing in northern Alberta, and I'll just say for my area, generally speaking, there are a lot of generalists. We don't have post-secondary graduates from our communities. They're very, very few and far between, and they don't stay. When they do get a post-secondary education, most of the time they're moving to the urban settings. They don't want to stay and work in our communities. We don't have a high turnover of our nursing staff. We treat our nursing staff very, very well, and we just repeatedly and genuinely acknowledge their contribution to the community and the love and care that they give and go above and beyond day to day. And so we have long-serving employees. Transportation is a huge issue for us. Some of my communities that I work in are 3 hours to the nearest town and maybe an hour on gravel. That's horrendous. So we'll take out your, well, we've got some experience from a trip. We'll take out the bumper off your car. No problem. So transportation is a huge issue. Yes, there might be federal funds to provide transportation, but that doesn't always cover it. And then it's that human effort to get, okay, you've got to find a babysitter today for all of these children to get somewhere for one little test. So we find so often we've got people that are just, they're content and they try and manage as best they can. I'll move on. I'm sorry I'm taking up so much time. Some common approaches and characteristics to successful programs. In my experience, we need to respond to the needs of the client. So often we find that the first part of the discussion is money, and what will the money cover? And then we start figuring out what we can do with the money instead of looking at what the client genuinely needs and try and figure it out from that perspective. We need human capacity whose response is solely dedicated to work with individuals in a holistic manner. We need to train our lay people, certainly for our areas. We know we have to grow our own. We have to do that all the time. They understand their community, their environment, the resources around them, which are much different. And every community is different. And while you may find an Indigenous approach to something, just because it might work in a nation in Saskatchewan doesn't mean it's going to work in a nation in Alberta. You can get new and innovative approaches that have sort of a foundation that everybody could agree on, but we have to be able to leverage that and find unique response for the area that we're trying to target. We have to have jurisdiction-free response. I know certainly in Alberta we've got federal and provincial jurisdiction, and they fight, and we all fight all the time about whose problem it is and who's supposed to fix it. And we need to have access closer to the client. You know, far too often it's like, okay, well, we'll set this up here because it'll serve this group of 20,000. Well, that means everybody has to go there, but the road goes both ways. So that's my experience from the north.
Thanks.
It's been a pleasure joining you.
Thanks. There was another one or not, John?
Yeah, I think just quickly, I'll just go to someone who hadn't spoken, and then we'll just do some closing.
And then it's time.
I have a whole list of things written down here that have been coming to my mind as we've been going along. And I forgot to mention that I work in the health area at Southern Chiefs Organization. So working with 35 Southern First Nation communities, but also doing a lot of networking with the northern communities as well. So some of the things, that I was thinking about while this is going along is actually even going back one step, food. We're talking about proper nutrition and everything. And I think about even at our own office, we're even guilty of it, for the people that work in this, is that food is love, and food is celebration, and food is part of gathering. And it's hard to maintain healthy habits when food is part of our culture. And unfortunately, some of those things that are part of our food now, they weren't there just a couple generations ago. We didn't have flour. We live on bannock and fry bread now, and that was never part of what we used to eat. And with a lot of communities being displaced, during treaties being signed and moved away from the area where they used to be located, that's even changing what their traditional food was. What might have been fishing before is now hunting, or being moved up into a northern area where you have to learn about what your food sources are around you. And into the current age, again, even that gets cut shorter and shorter because of laws around hunting and fishing and so forth. Your jurisdiction area where you can even hunt is limited now to what it used to be. So those things have an effect on our bodies over the generations and how we process food, at a molecular level. I'm sure that has contributed to how diabetes has been, consistently on the rise, is just because our food sources are a lot different than they were just a couple generations ago. And then also, we're talking about drinking more water. Well, there's a lot of communities in our northern parts of Manitoba that don't even have running water, and access to clean water is an issue. We live in Canada and we still have third world, country problems in our own backyards here. So again, that's another thing that can contribute to our rates of diabetes in the north, is because it's easier to go get a can of pop than it is to get a glass of water from your own kitchen sink. And the prices are, just atrocious for getting healthy food. The further north you get, the more expensive it is to purchase food, purchase healthy food. The access to even getting any sort of fresh produce is more and more limited the further north you go as well, and the type of food that you get. I know even for my own First Nation community that's only 2 hours out of Winnipeg, you try to go to the local store there to buy stuff to make a healthy salad, and you have very limited options. Or you go to even a restaurant in my community, you can't order a salad, because we have unhealthy choices. It's kind of been ingrained in us, and like I said, it's a lot cheaper to eat unhealthy than it is to eat healthy, and all the preservatives as well. We even have a community, Churchill right now, who doesn't have its train accessibility anymore, and to try to get food into that community, again, prices are through the roof. Less access to that is probably going to make numbers go up even more and more. We spoke about the residential school part, and even having family who've been in residential school. My mom, my aunts and uncles. The thing of even eating healthy at that times and what they were able to have, even having being starved at times, and as punishment not being able to eat. So coming out of those areas too, eating habits aren't the best sometimes. Sometimes you eat just because you can, or I can eat whatever I want because nobody's limiting on what I can, what I can have. And again, food is love is kind of taught to the younger generations too, that you buy them treats because you can, when you weren't able to do that before. So again, it's unfortunate that we teach our younger generations, and I'm probably guilty of it too. I eat cheesecake more than I should. But those are habits that we have to try to get ourselves out of, and learning better options of better diets within our means, again, based on where community members live. What do they have available? You can give somebody a diet plan, but they might not have those things in their community. I remember not even being able to go get chicken breast or, healthy chicken that didn't have it being deep fried and frozen, that you go get from the freezer section. So making plans that are within people's means. The other thing I want to mention too was about funding. I know that everything shouldn't have a dollar sign on it, but it really does a lot of times boil down to funding. You know, it's just mentioned too about federal versus provincial. It's fought about all the time in our province on whose mandate it is, whose responsibility it is to fund these kind of programs. When funding does come down eventually, it's very short-lived funding. It's, you know, in small groups that it can, you know, people who can access this, programs that can access it, and it has barriers on who can access this program, and, you know, what you're allowed to deliver within, you know, the box of the program that the, you know, the feds or the province will fund for a little while. So it's very difficult to have proper intervention, proper prevention things, programs within communities when, you know, funding is a big part of it. And, you know, sometimes you finally get funding. You know, Manitoba, we just got foot care services in our communities, but on the other side, there's other cutbacks. You know, so you feel like you're getting two steps ahead, all of a sudden you're 4 steps behind again. So being able to have the, you know, funding that's sustainable and to see the benefits of it. Thanks.
Yeah, thanks very much. I'm sure there may be some others in the room, but we have run out of time. I'm going to turn this back over to John and Mahmoud. Thank you for participation. That's